at 12
Okay,
o'clock Eastern time.
all righty. So we'll begin the meeting. Good afternoon. My name is George Isham. I'm Senior Fellow at Health Partners Institute and Chair of the Committee on Informing the Selection of Leading Health Indicators for Healthy People 2030. I'd like to welcome everyone to this second meeting by web conference of the committee. I'm joined by my fellow committee members, whose names will shortly appear on the slide. Yeah, they're not there yet, but I appreciate all of them being on. Here they are. And we have, I think, a very talented and engaged group of people involved in this work, and we're looking forward to providing hopefully some good help to this very important effort. The task being undertaken by the Committee of the National Academy of Sciences, Engineering, Medicine is as follows. The Department of Health and Human Services, Office of the Secretary of Health requests that the National Academies of Science, Engineering, and Medicine convene an ad hoc committee to assist in the development of leading health indicators for Healthy People 2030. The committee will develop recommendations regarding the criteria for selecting these leading health indicators, or LHIs, and a slate of LHIs that will serve as options for the Healthy People Federal Interagency Work Group to consider as they develop the final criteria and set of LHIs for Healthy People 2030. This statement of task is provided in the attendee packet that has been made available on the meeting webpage. I would also like to give a brief overview of the agenda for today's meeting. We're pleased to be joined on the line by leadership from the Health and Human Services and from the Secretary's Advisory Committee. We will hear presentations providing detailed information about the work on Healthy People 2030. There will be 2 question and answer periods for the National Academies Committee. The first will follow the presentations from Don Wright, and then subsequent presentations from Dushenka Kleiman and Nico Pronk. Then will come the first question and answer period. The second question and answer period will follow the presentation from Terry Richmond. That second question and answer period may not only include questions for Terry, but might also include additional questions for the entire staff and speakers on the line. I would like to note that this is an open, on-the-record session. We have allotted some time at the end of the meeting for public comment. Given the web-based format of the meeting, we will ask that you submit public comments to the study director, Alina Bachu, rather than through the chat function on the web. So on the line is Alina's email, abaciu@nas.edu. So please note that if you're a member of the public and wish to submit either a comment or a question, please email her at that address and write public comment in the subject line so that we can appropriately flag and note these comments and respond to them hopefully quickly. Alina will read as many of the comments as time permits, but be assured that all of the feedback will be shared with the committee, and comments not read in this public on-the-record meeting will be placed in our public access file, as is the case with all materials shared with the committee. So I'd also like to remind everyone that this is an information gathering session. That is, the committee is in the process of assembling material that it will examine and discuss in the course of making its findings, conclusions, and recommendations. Therefore, I'm asking everyone today to be extremely mindful of the fact that the committee has made no conclusions at this point, and that it would be a mistake for anyone to leave here thinking otherwise. Comments made by individuals, including members of the committee, should not be interpreted as positions of the committees or of the National Academies. In addition, committee members typically ask probing questions in these information gathering sessions that may not be indicative of their personal views or the direction of their thinking. The committee will deliberate thoroughly before writing its draft report. Moreover, once the draft report is written, it must go through a rigorous review by experts who are anonymous to the committee, and the committee then must respond to this review with appropriate revisions that adequately satisfy the Academy's Report Review Committee and the National Academy's president before it is considered an official Academy's report. A statement about these matters has been included in the attendee packet as well. So with that brief front matter, and I think we'll move right to the agenda. And first on the agenda is an update about Healthy People 2030. And we're pleased to be joined today by Don Wright, who's Deputy Assistant Secretary for Health and Director of the Office of Disease Prevention and Health Promotion at the U.S. Department of Health and Human Services. So with that, Don?
Yeah, thank you, George, and good afternoon, everyone. As was mentioned, my name is Dr. Don Wright, and I'm the Deputy Assistant Secretary for Health and Director of the Office of Disease Prevention and Health Promotion, better known as ODPHP, which is in the U.S. Department of Health and Human Services. Thank you to the National Academies of Science, Engineering, and Medicine for the opportunity to provide an update on the efforts of HHS on the development of Healthy People 2030. And thank you to the public for joining today's webinar. At ODPHP, we set national goals and objectives for preventing disease and improving the health of all Americans. Congress created ODPHP in 1976 to lead the nation's disease prevention and health promotion efforts as part of the Office of the Assistant Secretary for Health. We do this work on behalf of the Secretary of HHS. Congress has tasked the Secretary with identifying national disease prevention and health promotion goals and laying out a strategy for achieving those goals. To accomplish this, we work with agencies across the federal family, like the Center for Disease Control and Prevention and the National Institute of Health, as well as national partners and stakeholders to set the national disease prevention agenda through the Healthy People Initiative, the nation's 10-year plan for improving the health of all Americans. Through Healthy People, we measure and track factors that influence health outcomes to ensure that all Americans have the potential to live long and healthy lives. The current initiative, Healthy People 2020, includes more than 1,200 objectives covering 42 topic areas. These objectives serve as national benchmarks that inform decision-making at all levels of government and across multiple sectors. The Healthy People 2020 Leading Health Indicators, also known as the LHIs, focus on promoting health and preventing health problems that have the biggest impact on Americans. LHIs are a smaller set of Healthy People 2020 objectives that have been selected to communicate high-priority health issues and actions that can be taken, to address them. The Healthy People 2020 LHI placed renewed emphasis on overcoming these challenges as we track progress over the course of the decade. The indicators will be used to assess the health of the nation, facilitate collaboration across sectors, and motivate action at the national, state, and community levels to improve the health of the U.S. population. As Healthy People 2020 is coming to an end, my office has been hard at work preparing for the next decade through the development of Healthy People 2030. Initiated in 1979, Healthy People is the nation's longest-running disease prevention and health promotion plan. Healthy People 2030 will be the 6th iteration of the initiative. The development of Healthy People 2030 includes establishing a framework for the initiatives, including the vision, mission, and foundational principles, the plan of action, and overarching goals, as well as identifying new objectives. In December 2016, HHS established the Secretary's Advisory Committee on National Health Promotion and Disease Prevention Objectives for 2030 in order to provide an independent recommendation from external subject matter experts in the fields of public health and healthcare, all aligned to inform Healthy People 2030. To date, the Secretary's Advisory Committee has met 13 times since their inaugural meeting in December 2016. As part of this work, the committee developed the Healthy People 2030 framework, which was revised based on public comment and departmental review and accepted by the HHS Secretary in June 2018. The committee also issued recommendations for developing objectives for Healthy People 2030. Charged with helping HHS to reduce the number of objectives in Healthy People 2030 to make the initiative more streamlined and efficient, the committee considered data needs as well as HHS and stakeholder priorities when developing their recommendations. HHS used these recommendations to put together a slate of 355 core, 800 developmental, and 25 research objectives, reduced the number of objectives by nearly 2/3. Recently, from December 2018 to January 2019, members of the public, both individuals and organizations, were invited to provide comments online via healthypeople.gov on the proposed objectives for Healthy People 2030 and propose additional objectives for consideration. During today's presentation from the co-chairs and members of the Secretary's Advisory Committee, you'll hear more about the objective categories for Healthy People 2030, that is the core, developmental, and research objectives, as well as the process for identifying objectives. During the public comment period, HHS received almost 5,000 comments, including comments received online via the public comment platform and via email. This included 1,732 comments on core objectives, 327 comments on developmental and research objectives, and 530 new proposed objectives through the online public comment platform. In total, 2,589 comments were received online. In addition, 2,135 comments were sent via email. Currently, the department is working to review each of the public comments received and make a determination for a revised slate of objectives for Healthy People 2030. In the coming months, ODPHP will send the slate of objectives to the HHS Secretary via the departmental clearance for review and approval. The launch of Healthy People 2030 is anticipated in early 2020. My colleagues from ODPHP, the co-chairs, and the members from our Federal Advisory Committee and I are pleased to be a part of today's webinar as the National Academies of Science, Engineering, and Medicine start the important work of developing leading health indicators for Healthy People 2030, which will represent the nation's highest public health priorities. This effort will run in parallel to our work in the department to finalize the Healthy People 2030 objectives. The National Academies were instrumental to developing the leading health indicators for Healthy People 2020, and we know that your insights will prove invaluable in identifying these objectives, these key objectives for the 2030 initiative. For Healthy People 2030, we request that the National Academy's LHI Committee select the leading health indicators from the set of core objectives that will be included in the final slate of objectives. Core objectives are considered high priority objectives that have, first, an identified data source or potential data source, secondly, a baseline data, and thirdly, assurance of at least one additional data point throughout the decade. Selecting leading health indicators from the core set of objectives will allow the department to monitor and track progress through the decade. Well, thank you for your time. And with that, I will turn the webinar over to the co-chairs of the Secretary's Advisory Committee on National Health Promotion and Disease Prevention Objectives for 2030, Dr. Dashanka Kleiman and Dr. Nico Price. Nika and Dashanka?
Yes. Thank you very much, Don. We appreciate the opportunity, and thank you to Dr. Esham and the members of the National Academies of Science, Engineering, and Medicine Committee on informing the selection of leading health indicators for Healthy People 2030 and giving us this opportunity to present our work. Nico and I will first provide the general overview of the framework and highlights of select subcommittees and the committee's deliberations, followed by Terry Richmond's presentation of the committee's report on leading health indicators. Terry has spearheaded 3 of our subcommittees, including the Leading Health Indicators Subcommittee, Ed Sondick also joins us, and Ed leads the data subcommittee, the longest running subcommittee, and one that provides the backbone to Healthy People. And we welcome Ed adding comments as he feels appropriate. So with the next slide, as Don mentioned, our committee membership reflects a diversity of backgrounds and expertise with experience in various settings: health departments, nonprofit entities, health systems organizations, academia, and others. We've benefited from the work and experience of the Healthy People 2020 Advisory Committee chaired by Jonathan Fielding, who now serves as the Chair Emeritus for our Healthy People 2030 Committee. We also have received incredible support from the Office of Disease Prevention and Health Promotion staff, learned from the contributions from numerous experts and program directors who have provided details of the history and evolution of the initiative, as well as real-world accounts of the use of Healthy People. All of this input has contributed to the work of the subcommittees and the committee deliberations and recommendations. Next slide. Dr. Wright highlighted the work of the committee in response to its overall charge, and our charge is broad. The committee serves to advise the Secretary on select issues related to the development of Healthy People 2030, including providing advice, as mentioned, on the organizing framework, selection of leading health indicators, and on the criteria, approaches, and priorities for selecting objectives in order to streamline and significantly reduce by 1/2 or more the number of measurable objectives and identifying those that are most salient for national tracking by HHS. So central to this part of the charge is advice on the reduction of objectives with considerations that include but are not limited to the quality, availability, timeliness, and dissemination of data, and opportunities for new data sources and measures that are relevant and can be used at different levels, the state, tribal, local, and county levels. And also consideration was given to emerging health issues, the burden of disease, the strength of evidence for interventions, and the assets that well-being bring. In addition, the committee was asked to provide advice on implementing Healthy People 2030, including stakeholders in the private and public sectors, and for monitoring and reporting on objectives. Next slide. As Don mentioned, we've had 13 meetings, 3 of which have been in person and others conducted as webinars. An additional webinar is scheduled for June 26th, and the information for access to that webinar is on the Healthy People website. Next slide. We've used subcommittees to initially address each aspect of the charge, and the subcommittee reports provide draft recommendations and inform the deliberations of the full committee. We have a total of 16 subcommittees, 13 of which have completed their work. 3 are ongoing, the data, graphics, and implementation subcommittees. And for today's presentations, we're drawing predominantly from the subcommittees that are highlighted in red. Next slide. We have delivered multiple reports to the Secretary, and I have stakeholders on my mind because it was a very important part of our thinking and deliberations. So these are the reports that have been presented, recommendations for the approach to Healthy People 2030, recommendations for developing objectives, setting priorities, identifying data needs, and involving stakeholders for Healthy People 2030. This also included appendices that provided a revision of the framework and our recommendations for social determinants of health and health equity. Another report focused on the leading health indicators that we will hear from in the course of this meeting, and then reports on target setting methodologies and on stakeholder engagement and communication, which is extensive and identifies multiple sectors and provides information of the role of these various sectors and stakeholders that are eligible to partner with supporting health and well-being. Next slide. We still have 3 reports to transmit to the Secretary. One is on the review of the Healthy People 2030 objectives. We concurrently, while public comment was sought on the draft objectives, we also reviewed these in the context of our framework, and that will be coming forward shortly to the Secretary. And finally, reports on implementation and on the graphic for Healthy People 2030. Next slide. So in the course of our presentation, we will be giving highlights and overview of our framework, and I will do that part. Nico will be presenting specifics related to our objective and data deliberations, and then Terry will speak to the leading health indicators, efforts, and reports. Next slide. So in our charge, we were asked to provide advice on an organizing framework. We realized at that time that in addition to addressing the charge, we as a committee would benefit from creating an approach allowing us to create a common platform before moving forward with many of the other parts of our charge. And so we titled our first subcommittee Approaches, and that was led by Terry Richmond. This work resulted in our first report, was circulated for public comment. And based on that feedback, as I said earlier, the revision was in Appendix B in our second report. The resulting framework provides the context and rationale for the initiative's approach and acknowledges that 2030 marks the 5th decade of Healthy People. It's pretty awesome as far as I'm concerned. We added a background, past and present, to highlight major accomplishments since the launch of Healthy People, the lessons learned, and also acknowledge challenges, areas where progress is lagging, and opportunities for the future. A specific reference was made to our standing in relation to other OECD countries and our need to commit to close these gaps. In addition, we were intent to clearly communicate with and reach diverse stakeholders, and so the framework uses clarifying statements to delineate each section, such as what Healthy People contributes in the background section, and other statements throughout. Next slide. So, as you can see here on our vision, where we are headed, a society in which all people can achieve their full potential for health and well-being across the lifespan. And our mission, why we are here, to promote, strengthen, and evaluate the nation's efforts to improve the health and well-being of all people. You will begin to note the mantra of health and well-being that starts with the vision and mission, and it's seen throughout the framework and our work. Next slide. The next 2 slides include our foundational principles, what guides our actions. We realize that the need for principles to guide the work of the committee and our subcommittees was really important, and we needed this as a foundation, not only for us, but for stakeholders and others. This component is a new part of the Healthy People framework. What evolved was a set of 7 principles that explain the function and orientation of Healthy People 2030. And I will go through these, but I want you to note again that the 7 principles focus and highlight health and well-being throughout. So health and well-being of all people and communities are essential to a thriving, equitable society. Promoting health and well-being and preventing disease are linked efforts that encompass physical, mental, and social health dimensions. Investing to achieve the full potential for health and well-being for all provides valuable benefits to society. Achieving health and well-being requires eliminating health disparities, achieving health equity, and attaining health literacy. Next slide. Healthy physical, social, and economic environments strengthen the potential to achieve health and well-being. Promoting and achieving the nation's health and well-being is a shared responsibility that is distributed across the national, state, tribal, and community levels, including the public, private, and not-for-profit sectors. And working to attain the full potential for health and well-being of the population is a component of decision-making and policy formulation across all sectors. And these are not in any order, but they have, of course, infused our thinking, our shared thinking as a committee, and then infused the work of the subcommittees. Next slide. So the principles inform the development of the overarching goals, what we plan to achieve. We have 5 goals. In 2020, there were 4 goals, and there are similarities from 2020 to 2030 with a few additions and areas of emphasis. Again, these are not in any order. So as you can see, attaining healthy, thriving lives and well-being, free of preventable disease, disability, injury, and premature death is as we look to achieve this. The second, eliminate health disparities, achieve health equity, and attain health literacy to improve the health and well-being of all. This is a renewed commitment and emphasis to achieving health equity and eliminating health disparities that has been part of Healthy People in 2020 and in some cases earlier, and with a new addition from our foundational principles, attaining health literacy, defined as occurring when a society, institutions, providers, and media, for example, provide accurate health information and services that people, such as communities and populations, can find, understand, and use to inform their decisions and actions. The third is create social, physical, and economic environments that promote attaining full potential for health and well-being for all, and this reflects an addition of the economic environments from the 2020 objectives, overarching goals, promote healthy development, healthy behaviors, and well-being across all life stages, and a new overarching goal, engage leadership, key constituents, and the public across multiple sectors to take action and design policies that improve the health and well-being of all. So our plan of action in the framework, which is what we propose to do, is really giving us the tools and the opportunity to move the health and well-being of the nation forward. So what do? We set national goals and measurable objectives to guide evidence-based policies, programs, and other actions that improve health and well-being. We provide data that is accurate, timely, accessible, and drive targeted actions to address regions and populations with poor health or at high risk for poor health in the future. We foster impact through public and private efforts to improve health and well-being for individuals of all ages and the communities in which they live. We provide tools for the public, programs, policymakers, and others to evaluate progress towards improving health and well-being. Next slide. We share and support the implementation of evidence-based programs and policies that are replicable, scalable, and sustainable. We report biannually on progress throughout the decade from 2020 to 2030. We stimulate research and innovation towards meeting Healthy People 2030 goals and highlight critical research, data, and evaluation needs. And we facilitate development and availability of affordable means of health promotion, disease prevention, and treatment. Next slide. So the issue briefs, they were not part of the charge to our committee. However, when the public comment period informed us after taking a look at the framework, the initial framework that was put out for review, we realized that there were several topic areas that were within our framework and also processes that were important for moving and understanding the framework itself and moving Healthy People 2030 forward. So we developed these issue briefs in order to provide definitions of the terms, to identify the role of these concepts that they had played historically in Healthy People, and also looking forward as to what they can do for Healthy People 2030, and also focused on methodologies. So these are now available to everyone to be able to inform the work of stakeholders and partners. Next. These subcommittees covered, as you now have seen, within the various foundational principles and overarching goals, the topics of health and well-being, health equity, health literacy, health promotion and disease prevention, bringing us back to our original roots, law and policy as determinants of health and well-being, and also 2 briefs that really take a look at ways in which we can benefit from complex system science and modeling, and also the use and application of summary measures of health and well-being. Next slide. And I'm going to turn this over now to Nico, because the health and well-being, he is our health and well-being champion. So as we go forward, Nico, do you want to take over at this point in time?
Sure. Thank you, Dushenka, and thank you to the National Academies Committee for the invitation for us to come here and inform on our work on developing Healthy People 2030. As Dushenka referred, health and well-being is sort of foundational to the entire framework, and it has really been a great way to anchor our work as we've gone through the different subcommittees and have conducted the deliberations of all of them. At the end of the day, we do need to, as a committee, we did need to make sure that we had a shared understanding of what we meant by health and well-being. And where we landed was that health and well-being refers to how people think, feel, and function at a personal and social level, and how they evaluate their lives as a whole. This definition clearly refers both to people at an individual level, but recognizes sort of the multiple levels that are involved in well-being. So at a personal and social level, and then this opportunity for people to reflect on their lives and how well they do in their current situation. The novel focus on health and well-being in Healthy People 2030 is indeed significant. It demands a shift from thinking about goals and objectives that have traditionally been set in the context of deficits and disease, rather than thinking in terms of assets and potential. So there is a bit of a mind shift, if you will, that is introduced by adding well-being to the health part. And in fact, when we think about health and well-being in the context of our work, we almost think of health and well-being as a single term. Subcommittees have centered their discussions and development of their recommendations around the Healthy People framework. So time and again, we've been able to go back to the framework, and it has allowed us to be guided, if you will, by the key recommendations that we will discuss today, including the objective prioritization, the objective review, the stakeholders, the communication, data, and health equity, as well as implementation, in addition to the leading health indicators that are the focus of today's meeting. So next, we will discuss the Healthy People 2030 objective and data recommendations. And I want to make sure to let you know that Dr. Ed Sandek is also on the phone. Ed has been our leader and chair for the data subcommittee, which has been active throughout our work over the past couple of years now. He's on the call, and even though I'm presenting the slides at any time, Ed, feel free to interject or at the end of the presentation add any insights that you may have as well. Let's go to the next slide. The objective selection process really provided a set of very strong reasons why we wanted to focus on the selection process in and of itself. First of all, one of the major charges of our committee was to decrease the total number of objectives from Healthy People 2020 by more than half. So there are more than 1,200 objectives currently in play. So that means that we need to end up with something less than 600. And that in and of itself is a task, a relatively large task. Next, there is a commitment to objectives based on strong data, sources, and evidence-based decision-making. And here the focus is really to make sure that we have, that there are actions that can be taken to improve the targets towards progress towards targets, so that if objectives are not actionable, because there is no evidence base, the likelihood of that actually happening is much declined. So there is a real commitment to prioritize towards objectives that are supported by an evidence base. Ensuring that those effective interventions are available for each objective will definitely support its achievement, or at least its potential towards achievement. The advisory committee then ended up looking at a three-step process to work through the development, the selection, and the prioritization of objectives for Healthy People 2030. The first step is basically to focus in on the topic. Select a topic that will be used to organize objectives and convene work groups. Secondly, to come up with a set of preliminary objectives using a set of criteria to objectively consider them. Inclusion and quality control criteria, and then based on that set targets. And then the third step is to categorize the refined list of objectives and prioritize them based on expected impacts. Basically, that categorization drove the development of the core objectives, the developmental objectives, and the research objectives that we will discuss here in a second. The recommendations related to step 2, which is that identification of objectives, basically follows this set of objective criteria. First, the objective should address an issue of national importance. Secondly, support the Healthy People 2030 overarching goals coming from the framework. The objectives should be measurable, it should be useful and understandable, and it should be updated periodically to reflect major updates and new knowledge. In addition, it should address the objectives should address a range of issues. They should include scientific evidence that the quantifiable measure is achievable, or evidence that we can move towards it. So they need to be changeable. Be directed towards improving health and well-being outcomes, as well as quality of life, which is an overlap with Healthy People 2020. They should address health inequities and health disparities in defined populations, and be based on valid, reliable, representative data and data systems at the national, state, and community levels. And finally, they should address social determinants of health, which is a linkage to health and well-being definitions as well. Regarding step 3, which basically starts to identify the linkage or the categorization towards these core developmental and research objectives, the prioritization recommendations then apply prioritization criteria to rank core objectives by expected impact. Healthy People 2030 should identify priorities and opportunities by applying a prioritization framework, generalizable to and usable by all target audiences. And their set of criteria should be applied to prioritize those core objectives. Overall health burden, both preventable and not yet preventable based on current opportunities. Preventable burden, that means an ameliorable fraction or amount of health and well-being to be gained from implementation of available effective interventions. To consider the health inequity and disparity reductions that are possible based on current opportunities, including opportunities to address social determinants of health, and include criteria related to cost effectiveness and prevention effectiveness. So that gets us to the discussion of the way that we ended up categorizing the objectives into three different categories: core, developmental, and research. The core objectives are basically the final objectives, if you will, that relate to Healthy People 2030. Objectives should be based on strong data so that they are measurable and can drive action. There should be also evidence-based interventions to address the issue in order to help assure that progress can realistically be made on the objective. Objectives should have an identified data source or potential data source, and they must address the core selection criteria that we'll discuss next. And there need to be targets set that are linked to the core objectives. The core objective selection criteria include measurability, a data cutoff for inclusion of Healthy People 2030. An objective must have at least have 2 data points in addition to the baseline throughout the decade. That they are objectives of national importance, meaning directly impact or influence on health. They are broad and comprehensive. They address a substantial burden, and they are relevant to national public health priority. That there is an existing evidence base for effective interventions that achieve the objective, and that they are related to health disparities and focus on health equity in order to achieve those cross-cutting objectives. The developmental objectives, on the other hand, are objectives that do not meet the data standards for inclusion as a core objective. They are important, but focus on a need to develop data. There is a focus there to develop the data sources and data collection efforts. There may be an evidence base for effective interventions to move the needle on, but there's insufficient data to comprehensively and regularly monitor that objective. And they represent high priority issues that do not have reliable baseline data, but for which evidence-based interventions have been identified. And finally, the research objectives, which are objectives that do not have strong data sources to measure the burden of an issue, nor evidence-based interventions, but they may represent public health concerns that have a high national importance or are emerging issues. They have a focus, or their focus be on a need to advance research and develop evidence-based interventions, and they represent significant opportunities for advancement in areas with limited research. A high degree of health or economic burden may be addressed by them, or an evidence base of substantial disparities between populations. So now we shift a little bit towards specific recommendations related to the data itself. So we had, as a committee, we had developed 4 specific recommendations regarding actions to ensure that data is in fact underpinning the Healthy People 2030 objectives in order to fulfill those criteria. For core objectives in particular, facilitate trend assessments, recognizing trends having at least 3 data points, and support objective achievement. First, the timeliness of the data. For People Healthy 2030 objectives, the data should be made available as soon as possible and no later than 1 year after the end of data collection. Frequency, data collection should occur annually. That there is a number of data points, as I said, at least 3 data points within the decade. And that may include a data point that comes from the prior decade if it's an objective that is carried over and carried through. And finally, data syndication. So recognizing the process of publishing the same database on many websites, including updates. And those efforts should continue for Healthy People 2030, and they should increase in frequency as well. In addition, there are 2 additional recommendations on data requirements, one related to data quality and one related to community data. The data quality part is to make sure that as the objectives are being selected, that the quality of existing and potential data sources is considered as based on currently accepted and published data standards. The community data recommendation is a theme that has been picked up by other subcommittees as well, and we'll probably see that come up again here in a couple of minutes when we talk about additional subcommittee recommendations beyond the data subcommittee. But these are basically to support programs and inform policies to meet the objectives and the data specific to the communities that they refer to, and the need to have that reflected. So HHS should work with communities to frequently update community level information, and that community level information should be used together with national, state, and tribal data to enable accountability, surveillance, and decision making. It is the type of recommendation that would allow us going forward to create, if you will, a line of sight between local applications and the national Healthy People efforts around data needs and data use. Next, yeah, thank you. So the different subcommittees that are still working today also have at many points considered the role of data. And in the recommendations that are still forthcoming, particularly from the Objective Review Committee as well as the implementation subcommittees, the role of data is clearly important. So, for example, in the Objective Review Subcommittee recommendations on the next slide, we note that the cross-cutting objectives are focused on mostly on morbidity and mortality at this point. We would like to see an addition of an additional set of objectives that explicitly address upstream determinants of health and well-being, health promotion, public health infrastructure, and disaster preparedness, as well as health equity and health literacy. I think this is an example of where this shift in thinking, driven by adding well-being to the health definition, is starting to show up in the existing objectives versus those that start to be more reflective of the overall direction that our framework is heading in. The next recommendation relates to the importance of prevention, and that in addition to looking at disease prevalence, there needs to be an increased focus on disease incidence, the prevention of a disease in the first place. And finally, to create a systematic and regular process to assess progress in meeting the overarching goals of Healthy People 2030. And this reflects a broader assessment at a higher level than individual objectives by themselves. The assessment should involve stakeholders, supplementary national or local data that inform progress in meeting these overarching goals, and may be informed by the ideas expressed in some of the issue briefs that are now in fact available on the website. So this may drive the need for additional metrics designed for this purpose. Related to the implementation subcommittee recommendations that are also still forthcoming, the implementation subcommittee has discussed these data and objective review considerations as well, and some of their deliberations are also potentially important for the LHI development of LHIs for the Healthy People 2030 effort. So the subcommittee has emphasized the importance of the adaptability of objectives particularly so that they can effectively address local needs and facilitate multi-sectoral efforts to achieve the objectives. This allowing for development of local objectives that have a line of sight to the national level Healthy People 2030 objectives is key in the notion of seeing action at the local level in alignment with where the national objectives are heading. Encouraging the use of Healthy People objectives in ways that are locally relevant in order to see that action show up, and then to contribute to achieving progress on the national objectives. And finally, building a compelling story that uses the release of LHIs to energize action and data use. And here I think you can start to see that much of these recommendations refer to our interest to see lots of action at the local level in order for us to, as a nation, achieve these overarching objectives. In addition, we have several more meetings on our schedule, including a Secretary Advisory Committee meeting in June, and several reports that relate to the Objective Review Subcommittee and the Implementation Review Subcommittee, as well as the Graphic Subcommittee that are forthcoming, some of them very shortly, others later this year. So let me stop here and ask Ed if you have some additional thoughts or comments before we go to Q&A.
Thank you very much, Nico. That was terrific. I would just, on the data side, emphasize a couple of points, I think. One was back on slide 22. You don't have to go back there, but there was it emphasized that it's important to have an evidence base to drive action. And I think this has been a theme throughout the discussions on data. And I should point out our data discussions are continuing, as Dushanka had mentioned. A couple of things we're focused on are how best to provide guidance to those who are implementing Healthy People. And this is guidance at the state level, but also increasingly at the community and the local level. And the guidance here is crucial about quality, about data analysis, about data sources. And we've also had and are continuing discussions on the thought of building data partnerships across the United States in which we would link data sources, data mavens, if I can use that term, data, the implementation of data and analysis and use in decision making. This notion of the community and local data is becoming another really important theme. And it was on one of the slides that Nico showed. And it's particularly important to drive action. Action at the national level is crucial, but it's at the local level where we think we'll see the greatest impact. And there are questions about how to provide data and to link it in such a way. I might point out that this is a topic that not only we in Healthy People are thinking about, but the National Academy's Committee on National Statistics has a seminar upcoming at the meeting of the Committee on National Statistics on May 10th. It's going to focus on linkages among federal, state, and local data. And we think that we're going to be seeing much more of this over the coming decade. And it's not as if we know how to do it. In fact, there's a lot of challenge associated with it. But getting data that is most relevant at the community level is critical, we believe, to drive action. Nico, thank you.
All right. Thank you very much. Are you concluded, Nico?
Yes, I was just going to hand over to you, George.
Right. Thank you very much. Well, first of all, I want to thank so far what we've heard. I mean, amazing. We've got Terry coming up, but it's very, very clear that the efforts of HHS, as well as the advisory committee and all of its various subcommittees, has done an amazing amount of work and produced a lot of material for us to think about, and a lot of good thinking has gone into this. I want to really make that point right off the bat. We're very impressed with the amount of work that's done. To open the question and answer period, we've got just about a little less than a half hour here. I want to ask a general question first to get us started. It seems to me that and Don Wright mentioned this when he was making his introductory comments about the effort spanning, I believe, since 1979, over 5 decades of effort, a really remarkable achievement focused on disease prevention, health promotion, disease prevention. On slide, I think, slide 17, I think when Dushenka was talking about the issue briefs, there's a list of those issues, of which disease prevention, health promotion, disease prevention is one item. And then you transition to NICO, where you started talking about health and well-being, and then the cross-cutting objectives on slide 33. It appears that there's tension between the history of this program and the rapidly developing field of our understanding of what creates health that's occurred in the last couple of decades, and the need for continuity with respect to the program in terms of measurement, data sets, and evidence and so forth, which takes time to develop. It appears there's a tension between the rapidly developing understanding of what creates health and what we have in the past focused on in terms of health promotion, disease prevention. I'm wondering how the advisory committee and HHS is thinking about this tension that is created by that sort of observation.
Maybe I can start and invite others to join that question as well. I think it's a great question, George, and I think you're reflecting some of the reason why our committee ended up thinking about this in the context of introducing this notion of health and well-being. In a sense, the definition, and I think this is laid out fairly nicely in our health and well-being brief. The idea of the definition of health and well-being and how we talked about this is to, in a sense, build a bridge between what was traditionally more a focus on prevention of disease towards this notion of thriving in communities. And how do you get the connection between traditional focus on health versus the causes of health, which are these social determinants? And so in a sense, the health and well-being focus ended up allowing us to connect those two into a different area of focus. So I don't think that as a committee we have necessarily thought of it as a tension, as you put it, but I think that is an accurate reflection of where the field is heading. And so perhaps that idea of a bit of a mind shift from only health to health and well-being allows us to start thinking about these broader issues that are reflected in social determinants, to bring those into this developmental field, if you will, and address that issue. Let me invite others to reflect as well.
I'll jump in for a minute, Nico. This is Terry. Is that okay, Dushenka? Or?
Sure, go ahead, Terry, and they'll follow you.
So, I mean, I do think that there is a bit of a tension there and a recognition of the upstream determinants of health more overtly than in the past. And the objective review subcommittee report is not out, and we're not presenting that today. But I think we saw that play out in the original set of 330 some objectives that we reviewed, potentially for the draft set of objectives for Healthy People 2030. And one of the reasons, and Nico said this in his presentation, that we recommended at least the addition of 10 cross-cutting objectives that really could address upstream determinants of health and well-being. So I think important. And I think in terms of, and that's why the foundational principles are so important. And I think as we see those core set objectives become finalized, including more that overtly address those upstream determinants will be important, and certainly was a recommendation from our committee.
Mm-hmm. So if I could just add to what Nico and Terry said, and maybe go back to the WHO definition of health, which basically highlights the state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. So within the context of sort of going back to go to the future, I think the fact that well-being is there, we understand it in a different way. We have defined it much more broadly through the social determinants of health, documentation, process, and partnerships. And I think that Terry's point about the way in which we have taken a look at the original draft objectives and seen that the pattern of how we've done it in the past is still there, but to think differently and to balance the objectives so that we're able to reach the full spectrum, including the upstream determinants, and encourage partners from other sectors in a very effective and deliberate way is something that I'm seeing as an extension, not just the tension of what we have been doing in Healthy People.
Thank you. Other questions from the committee? I know both Martha and Darcy have committees that are relevant in this section. Martha or Darcy?
Hi, this is Darcy. Can you hear me?
Yes, we can.
Okay, wonderful. I was trying to make sure I could unmute myself. So thank you so much for these presentations. They're very helpful. And I wondered maybe if Ed could speak more about the emphasis on local and community data, being the place where action can truly make a difference, and thoughts that the group had possibly on data at the sub-county level, and how that could come into play.
Well, I'd be happy to, but I think the last point that you just made is really a challenge, because there's really a question of always the question of the quality and how this should be able to make this. George mentioned attention. I think I've seen, and this is true in my days at the National Center for Health Statistics, there was a tension between promulgating the use of national data, which is crucial to giving us a picture overall, versus what do we know at the local level, and what data can we use to give us the biggest bang for the buck at that level, and the need for expertise at that level. So I think this is, I think it's a challenge. I think there's a tension that I think will probably be, in a way, going or lessening as there's more emphasis and more approval and more guidance on how to use information that's available locally. But I can't emphasize enough, from what I've seen, there's a lot of talk of this, and I just mentioned the Committee on National Statistics holding a seminar on it, and there are other activities going on around the country on this. But at the same time, there are questions about how best to use this information. And so I think the guidance side is going to be particularly important.
Yeah, and if I can add to that, in the presentation we did mention this idea of data partnerships, which I think has a lot to do with this objective of reaching or adapting, if you will, objectives at the local level and drive local data towards those objectives that then can sort of roll up into national represented objectives and targets. So there are quite a few of those efforts going on around the country today, where lots of different organizations work together towards a standardized approach to collect data. And I think that those data partnerships may really help us think through what kind of approaches to take there. But this idea of adapting objectives would be a sort of a new way of thinking about healthy people at the local level.
Okay.
Great, thank you.
Thank you. That was Darcy Emmerich Phelan from the epidemiologist at the Baltimore City Health Department. I realize we haven't introduced everybody. Are you finished, Darcy, or did you want to add anything?
The only other thing, just thinking about data partnership, I wondered if the group had considered the role of health information exchanges. Here in Maryland, we have one health information exchange for the whole state, which I understand can be unusual. So I don't know if you want to get into the weeds about all the different data sources, but I guess just wondering your thoughts on perhaps partnerships with health information exchanges.
I certainly, this is Ed Sondick, I certainly think that's potentially one way to go. But one of the things I think we're kind of missing is just a reasonable inventory of the possible ways of doing this. We've had in the discussions we've had, I think, a very positive response to this general idea. But how best to do it is another story. There are some locales around the country. Since these locales differ in what they are, I just use that sort of general term in terms of the sophistication. And there are some with very sophisticated tools for analyzing and tracking information, and others that really aren't there yet. So I think some sort of a partnership here between guidance and providing information and exactly, where this role should come from. I'm really pleased to see the Committee on National Statistics taking a look at this. But I know the ASA, the American Statistical Association, there's another organization called NISS, that is also interested in this. It may be that, just to throw out a figure, that perhaps in a year we could get the significant players in this together and think about a strategy that we can couple with healthy people to move in this direction. Now, this is easy for me to say as essentially a person who is happens to be on the committee and very happy to be that. But where leadership should rest in this, I think, is an interesting question.
So let's move to, I think, Jonathan Skinner, who is in the Department of Economics at the School of Medicine at Dartmouth College, has a question also on. And as long as we're on that topic, Jonathan, are you interested in asking your question at this point? You can unmute yourself. I'm not sure that Jonathan's there yet. Martha Gold, can we go to you for a question, and I can come back to Jonathan?
Sure thing. Hi there, everybody. Thank you for that very rich report, and you've covered a great deal of information in a very short period. I'm impressed. I was particularly intrigued by some of the conversation that Nico and Terry then talked about in terms of the cross-cutting objectives, and sort of eager to hear more about those as they develop. One of the questions I really have is the extent to which the advisory committee has considered whether leading health indicators should take more of an individually oriented approach, sort of an aggregation of individual experience, versus a population-based approach to the health of Americans. And that's an important issue in terms of thinking about the evidence base. And I want to go back to things that were talked about in slides 21, 23, and 27, which is what are the criteria that constitute a sufficient evidence base such that they can be considered to drive action. There are, in clinical worlds, there are RCTs. In population health, we're more into the world of observational studies, associations, ecological data. I think this is a really important issue for us to understand the advisory groups thinking about what constitutes a sufficient evidence base.
Yeah, I think great question. In terms of the last part of your question, what constitutes the evidence base, I think we're thinking about, for example, the Community Services Preventive Services Task Force, which is focused on community-based interventions and uses a methodology that goes well beyond randomized controlled trials. So those type of sources of evidence would sort of be prioritized, at least from my perspective, and how that would relate to an existing evidence base. In terms of the objectives themselves and how they relate to the leading health indicators, if you will, and perhaps this goes back to the first question about how do the leading health indicators at the end of the day reflect a field that is now broadening into the variables or the drivers that create health. The leading health indicators have been traditionally defined as being a subset of the existing objectives. So you end up with a subset of fairly focused objectives across a variety of areas. And I guess when I think about cross-cutting objectives, perhaps that is no longer sufficient, and that we need to start thinking a little bit beyond any specific objective, but a set of metrics that reflect more of either a population perspective or a cross-cutting perspective. And that may actually be one of those questions that could be addressed by the summary measures of health and well-being brief that we wrote for that purpose as well.
May I ask a follow-up question then, just about the summary measures? About what kind of thinking has gone into. I didn't see in the initial set of objectives something that looked to be an idea for a summary measure of population health. Is that work that's potentially going forward within this version of Healthy People 2030?
I think, so I'll start by this, but probably Ed would have some thoughts about this as well. My view on this would be that at this point, we've sort of introduced this idea that in order to periodically reflect on how well the program Healthy People 2030 in general is doing, you would have to come up with some sort of a set of indicators that go a little bit beyond what the leading health indicators are designed to do. And this is where this idea of is there a summary measure kind of approach available to reflect on that? And so the thinking that we've had in basically the creation of the brief was to sort of say, well, there are those metrics that others have looked at as well and over time. For example, life expectancy or life satisfaction would be a measure that relates to an overarching way, a cross-cutting way of thinking about how well people are doing. And that could reflect sort of a personal view of health and well-being. On the other hand, a measure such as social cohesion would be a cross-cutting measure, but that would actually occur at the social level. So you would have a multi-level kind of approach to think about how the Healthy People 2030 overarching view that reflects, I think, the intent of the framework would do in a very limited number of metrics.
And I'll add to what Nico said. This is Terry. I think in one of the strong recommendations in the Objective Review Subcommittee report, which is still in the pipeline, was to meet that very need. Is to say, if we're just evaluating the core objectives, that's really important. But we need to get up at a bigger level and say, how are we making progress on the overarching goals? And I think summary measures, and I'll defer to Ed on this because Ed, this is your bailiwick, is one way to start looking at, are we actually making progress on the overarching goals of Healthy People 2030?
Mm-hmm. I can't believe I'm talking to Martha Gold about summary measures.
Pretty funny, Ed.
How many years? Yeah, I say that because this goes back really many years, and I think we are still looking for the appropriate, I don't know, or a set of criteria. But actually, if you look at the summary, the brief that we put together, it does give a kind of set of desiderata for this, as well as some narrowing of what they might be. For example, it mentions a single measure that would provide comparison or facilitate comparison with other countries. But then also, in addition to perhaps a single measure, to have another tier that would be focused in specific population groups and allow population groups to be measured. And then a third approach we talk about is the base of measures on the overarching goals for 2030. So we don't have specifics in it, but I think the emphasis is that summary measures are important, and you really can't get away from it. That anyone looking at the initiative will ask the question, well, how are we doing? And we need to be able to provide some guidance as to how we're doing, but that question in and of itself is kind of complex. One point we did come back to several times was the importance of comparing health in the United States with health in other countries. And that's something that in past editions of Healthy People that's not been emphasized. I won't say it wasn't there, but it really hasn't been emphasized. And in our discussions, we continue to come back to that, and then comparisons with population groups within our own country.
Great.
That's all great to hear. Thank you.
Thank you. Will that report on the overall objectives that's currently in progress be available to us, to our committee, as we do our consideration? Will that be available?
Yeah, that report is currently waiting for approval by the secretary, and as soon as that happens, it will be made available to the committee.
Terrific, thank you. Ebony, I know that you may have a question or may have been addressed, but let me call on you if you have a question.
I think my question was addressed. It was pertaining to the conversation. I think, George, you really brought up in the beginning, but it was sort of this transition going from the concept of the prevention of disease, sort of thriving communities, sort of where we are to where we're trying to go. And as I've been listening to the subsequent conversation, I'm wondering about your thoughts, the group's thoughts on how to drive the development of new data sources. As we're talking about this tension about, the core objective needing to be to measure, to be able to track trends. Yet many of these concepts that we're talking about that revolve around quality of life or social cohesion, we may not have appropriate data resources for those. Have you thought about how this effort helps to drive that?
I was just going to say, our discussions of data have really start with the data for specific objectives. The point you bring up, which goes beyond that, in other words, giving us a more overall picture of determinants of health that are not necessarily specific to particular objectives, is something that I hope we have the opportunity to continue and move in that direction. There seems to be such interest, strong interest across the country in many areas on this topic. I think trying to sort of get some sort of a handle on it, try to sort of pull it in and sort of formulate it so that we have a sense about direction in this area, I think would be extremely important.
Thank
but
you.
We have not focused on it.
Thank you.
No, and I think the point that Ed raised about the linkages and what is already happening with the growth of the federal statistical data research centers throughout that have allowed the federal agencies to at least provide their data and begin the formal linkages within to facilitate the answer to the type of questions you have, such as the housing and Haynes linkage as an example. Those are discussions that we hope are going to go on and be very fruitful and hopefully accelerate in the context of the coming decade, but early in the coming decade.
Okay, thank you. That was Ebony Bouwer from Duke University. I forgot to further introduce you, Ebony. So at this point, we are at 11:20 and our agenda calls for a brief break. And so let's do that. And then we'll return for Therese Richmond's presentation and a second question and answer period. And for members of the committee that have not asked a question yet, I'll probably go to you first to make sure that you get the opportunity to ask a question. But at this point, we'll take a break for 15 minutes. So depending upon your time zone, that would be 25 minutes to the next hour. So, okay, let's take a break.
Mm-hmm.
This is the time we said that the break would conclude. This is George Isham again, chair of the committee. I want to again make the comment that I'm very impressed with not only the work that HHS has done and the subcommittee has done and the various groups of the committee. I'm very impressed with that, but also the level of the dialogue, the responsiveness to our questions. So really appreciate that. With that, we want to move forward with the agenda. Therese Richmond, or Terry Richmond, is also a member of the Secretary Advisory Committee and chairs its subcommittee on leading health indicators. Leandria Laporte, Professor of Nursing, Associate Dean for Research and Innovation, University of Pennsylvania, School of Nursing, University of Pennsylvania. And I know from other work we've done, just a terrific person. So Terry, you're on.
Great. Thanks, George. I'm happy to present the thinking of the Leading Health Indicators Subcommittee and the entire committee to this group and look forward to a dialogue after that. We can go to the next slide. So the committee members, I chaired it, were Susan Geckler, Dushanka Kleiman, Mary Pittman, Nico Pronk, Ed Sondick, and Joel Teitelbaum. It was an awesome group. We did our work over the course of 5 meetings. And in this particular group, they had homework assignments in between the meetings, which I'll explain because it's useful in thinking about our process and the recommendations. Next slide. So the charge of the subcommittee was to provide advice regarding the selection of leading health indicators for 2030. And essentially taking into consideration the framework as a foundation. And really the framework, as Dushanka talked about, has driven everything that we've thought about. And we're looking for a logical consistency throughout the entire program. That we needed to consider recommendations coming from all of the other subcommittees. And many of us across the full committee sit on multiple subcommittees, so there's a lot of cross-pollination, and that has been extremely helpful. To consider the definition of LHIs, what are LHIs, a possible redefinition, or even relabeling what LHIs, relabeling the terminology. To look at the use of LHIs in the past, thinking about the present and certainly moving into 2030, and how they can help achieve Healthy People 2030's mission and objectives. And looking at the alignment of LHIs with the selection of Healthy People 2030 objectives and priority areas. And finally, to recommend, as an advisory committee, criteria for LHI selection. So next slide. So the first, we had two recommendations, which sounds simple, but it was a lot more than that. One was to really take a look at the LHI definition. And we wanted this definition to reflect the Healthy People 2030 framework, remembering well-being is a new concept within this cycle, and settled on this definition that leading health indicators are a selected set of measures of determinants and sentinel indicators of current and potential changes in population health and well-being. So that it took us a fair amount of time actually to get to this definition, but I feel it really does reflect the work of the framework and the intent of the group. The LHIs are intended to communicate high priority health issues and actions that can be taken to address them. That was 2020's language, and we concur with that, high priority health issues and actions that can address them. And we build on that. So we're viewing leading health indicators as central to Healthy People 2030 in that they serve as a sentry, standing watch over the health and well-being of the nation. So it's just central, but that LHIs really need to catalyze actions and stimulate commitment of resources to improve health and well-being. In many ways, LHIs are the outward-looking face that most people associate with Healthy People program. In addition, we believe that LHIs need to serve as a bellwether and provide an early warning system for existing or potential threats to population health and well-being, and that each LHI alone provides critical data, but as a group or a set, we want the LHIs to provide comprehensive view of high priority indicators of health and well-being, early indicators of risk factors that impact morbidity, mortality, and well-being. So next slide, please. So to talk a little bit about the process, the criteria for the selection of Healthy People 2030 leading health indicators are obviously informed by the framework, driven by the foundational principles, and informed by the attributes of the core objectives. Nico presented the three types of objectives, the core, developmental, and research, and the reason that we have three different types. And the LHIs are drawn from the core objectives because by definition, as we've discussed, the core objectives have valid, reliable, and timely data sources and evidence-based interventions through which core objective targets can be met. That said, I'm reflecting back on the question and answer period from the at the end of the first part of this meeting, and I know George, I believe, asked if you would have access to the Objective Review Subcommittee report, and you will. I mean, it's been through the committee, it's now going through the pipeline. But I think one of the reasons we think that report is so important is if indeed we're to draw the LHIs from the core objectives, then having that set of core objectives reflect the intent and the changing thinking And Healthy People 2030 will be important if that's the pool of candidates for leading health indicators. And indeed, the Objective Review Subcommittee made 8 major recommendations. And what happened with that is we looked at the draft set of objectives, the 300 and I think there were 37 objectives. Let's use 350 as a round number. And we've already said some of the recommendations, so you've heard it. But we really need to make sure those core objectives reflect the changing face of Healthy People 2030. And 4 of the 8 recommendations are made for the FIW to take that under consideration. The FIW did a yeoman's job in bringing the objectives from 1,200 down to less than 400. It was an amazing job. And we're recommending clearly putting some additional core objectives in that really address many of the things that we talked about in the question and answer period last time. So that will be important, and sort of what that final set of core objectives are going to be quite important. So the evolution, so that's just a little aside, but I think is important to know. I'll talk a little bit about the evolution of how we thought about setting criteria or recommending criteria to select leading health indicators. And I'll just tell you like some of their early thinking because I think it is somewhat helpful. So we really gave a lot of consideration to what would be criteria for leading health indicator selection. And we moved from something that I will say is not uncommon in my experience that was really pretty complicated. And I'm sharing this with you because I think it helps illuminate sort of where we started and why we ended up with the recommendations that I'll go through today. We initially I'm using the word play, it was much more serious than that, but we initially played with variations of intersecting criteria. So for example, we constructed a grid or a matrix kind of thing with the dimensions and criteria. And we had 3 dimensions across an x-axis, and we had, 3 criteria along a y-axis, and thinking you could really rank each of the core objectives in each cell of that matrix and come up with these are the most important things based on these criteria. We didn't move forward with that in the way that I'm describing it because one of the things we had is our subcommittee members had homework assignments. Everybody went home having even participated in trying to think through this grid approach. And it was just unbelievably challenging, difficult, and complicated to execute. So I'm telling you that because you'll be setting up or recommending a process or criteria that was the path we went down, and maybe you can learn something from that. So we decided as a result of that to really try to make this clean and elegantly simple. So the next slide, please. So what we decided was the selection process for LHIs would incorporate attributes by which Healthy People 2030 core objectives are selected. Okay, so that when we talked about those, and I'll go into those again in more detail, but then with additional nuanced assessments about how do we prioritize and pull out of those core objectives, the LHIs, and we decided to approach that in a 2-phased approach. So we'll go to the next slide, please. So essentially the criteria for LHI selection is a 2-phase selection process that represents the foundational principles and overarching goals. So the first phase is to really assess all core objectives across 4 criteria, and I'll speak about those criteria in just a moment. The second phase was then to look at the potential pool or set of LHIs that emerged from the phase 1, and then subject that to an additional set of considerations prior to selecting or recommending a final set. And that these considerations would include an assessment of the LHIs as a group as opposed to individual LHIs. So the process, as you look at it, seems quite sequential, and indeed it would start sequentially. You know, like step 1 or phase 1 happens before phase 2. But the more important thing is it would be iterative. And we came to this conclusion as we did our homework in terms of how we apply those criteria. Tiffany, can I just see what's on the next slide? Yeah, so no, go back for a minute. So how we applied that criteria. So essentially, this two-step process really is not just step 1 and step 2, and then you would be done, but that essentially we would do step 1, we'd look at possible sets that would become the LHIs and pretty much go back and forth. And it would be a multiple opportunities to move back and forth between the phase 1 rankings and the phase 2 considerations of the LHIs as a set. And I'll give an example of that in a little bit. So the next slide. So in phase 1, the recommendation was to take all core objectives and assess them across 4 criteria. And we actually used the 4 criteria that were applied, that came out of the Objective and Prioritization Subcommittee, and that were applied to even the selection of core objectives. And those 4 criteria were 1, public health burden. So what's the relative significance of health to the health and well-being of the nation? You know, that's classically morbidity and mortality, but it's not exclusively that. And in fact, things that have a low public health burden, for example, an infectious disease, maybe because of vaccinations, could have a huge public health burden should people fall off, as we've seen, as we're all hearing now with the measles outbreaks, for example. The second criteria is the magnitude of the health disparity or the degree to which health equity would be achieved if the target were met. So public health burden is huge, but something with a smaller public health burden, but huge health disparity and health inequity could be critically important and could end up in a set of LHIs. And certainly, if we go back to the framework and the overarching goal to eliminate health disparities, achieve health equity, attain health literacy to improve the health and well-being of all, the firm belief of the Advisory Committee for Healthy People 2030 is we can't have a healthy nation in the face of extreme health disparities. Next slide, please. The third criteria is the degree to which this objective is a sentinel or bellwether. And again, this supports a Healthy People plan of action to provide data that can drive targeted actions. So it helps us identify regions or populations in poor health or at high risk for poor health. You know, certainly we loved the idea of a warning or a harbinger to the state of the nation's health and well-being. We think that this is important as we consider putting together a set of leading health indicators. And the fourth criteria is actionability. So everything in Healthy People 2030 should drive action. The intent is to improve the health and well-being of the nation. So we want LHIs that mobilize people, that we can change, we can meet targets, we can really make progress in health and well-being. So these are informed again by our framework and are essential. As we think about actionability, it's a multifaceted way of thinking. So it's not just the state of available evidence, it's actionable evidence, it's are these really modifiable, and it's the ability to improve health and well-being at a cost that's considered a good value. I think as Ed has said earlier, you know, is it a big bang for the buck? So I'm going to stay on this slide for a moment and explain to you how we sort of tested this out as a subcommittee. So we took these 4 criteria and thought, you know, if we were as individuals, if we did it as an individual exercise to apply these criteria, would certain things come to the surface, or could we remove certain objectives from consideration? Since we didn't have the working draft set of the objectives for Healthy People 2030, we just went back to 2020 and took the 12 leading health indicators from the 26 leading health indicators from 2020. And we created a grid, and we asked subcommittee members to individually rank each of those objectives across these 4 criteria that I just reviewed. And they were asked to rank it on a scale of 1, lowest importance, to 10, highest importance. And then we sum them up. So you can see for each objective of those 26 LHIs, the score could range from 4 to 40. We then rank ordered those LHIs by both mean and by median. So in some ways you could say it's artificial because we looked at the LHIs from 2020, but we wanted to see, could we apply the criteria? Could it work? Did it inform a rank order of objectives even within those existing LHIs? And could it inform a dialogue amongst the group about possible sets of objectives? So what we learned in applying these criteria that we're recommending from phase 1 is A, it was sufficiently simple and clear to execute. That B, even when there was variations in rankings of individual objectives, overall it pretty clearly informed a rank order of those objectives. So for example, in one criteria for an objective, you could see a spread. Somebody would score something a 1 and somebody a 10, right? And then we would have some scores that ranged from, you know, very clustered and not a lot of variability to a pretty substantial variability. So in some cases, the mean and median were very close, and in some cases, we saw very different rankings if we used the mean and median. The bottom line is it was effective in A, helping to rank order by mean and or median. B, it provided a very clear starting point for a dialogue. And C, we thought at this phase, you could possibly triage out the lowest scoring of the core objectives. And I'll talk a little bit more about that in a minute. So once individual people work at looking at the core objectives and sort of, I guess one could say quantitatively ranking them, then we go into phase 2, and we'll go to the next slide here. So in phase 2, the goal in phase 2 is that once we rank order according to criteria, there's a potential pool of leading health indicators that will emerge from phase 1. And that those indicators or those objectives would be then subject to an additional set of considerations. And indeed, you would have multiple sets of possible leading health indicators. So you could have, you know, set A, set B, set C, set D, that could be put together in different ways. So then at this point, the recommendation in terms of evaluating it is to evaluate it on comprehensiveness. So do the LHIs in any respective set represent a balanced portfolio or a cohesive set of indicators of health and well-being across the lifespan? Second, is there a balance? Are the LHIs balanced between common upstream root causes of poor health and measures of high priority health states. All right, so is there a balance? Adaptability. So is any given set of LHIs that are under consideration amenable to policy, environmental, or systems interventions at local, state, tribal, and national levels? And the fourth criteria in the second phase is accessibility, meaning are the LHIs understandable? Will they resonate with diverse stakeholders to drive action? Because the bottom line is that is what we want to do. So we can stay on this slide for a minute, and I'm going to think about what does it mean when we bring these two phases together. So let's think about the two phases together. Let's assume, just for round numbers, you're working with a core set of 350 objectives. So remember, back in phase one, if you triage out 50% of the low scoring objectives, now you're working with 175 possible candidates of core objectives to enter into a set of leading health indicators. If you triage out 75% of the objectives, now you're working with a set of core candidates of maybe 85, 87 to be considered in a set of leading health indicators. So you're starting with a smaller pool than the total 350 core objectives after phase one. So now in phase two, we have a smaller set of the leading health indicator candidates. You have some data on sort of the rank order of those core objectives that are still in play at this point. And now we can think about possible sets and ask ourselves, is the set comprehensive? Is it balanced? Is it adaptable? And is it accessible? Will it engage the nation? But then what happens, and this is where the iterative nature comes in, what happens if across all the sets that survived that phase one quantitative piece, that something really is missing from consideration, right? Then we need to go back to the triaged out objectives and give it a second consideration, hence the iterative nature. So the subcommittee thought and the full committee discussion, so this has been through the full committee, that together these two phases made sense, covered important criteria, hit high priority areas, could be done in a logical process that would drive informed decisions. And across the two phases, we're dealing with high priority public health burden, magnitude of health disparity and inequity, degree to which it's a sentinel or bellwether for the nation's health, to drive action, and that are comprehensive, balanced, adaptable, and accessible. So with that said, I think that gives you an overview of how we thought about leading health indicators and what we thought the important criteria were and a potential process for carrying it out. So on that note, I think that's our last slide, and I probably will hand it over to George to open questions and answers, unless Nico or Dushanka or Ed, do you have anything you want to add to this?
No, that was terrific.
It was wonderful, Terry. Thank you.
Okay, thank you very much, Terry. What a remarkable set of work and terrific work the committee's doing, and actually a very nice presentation of presenting a lot of complexity in a very succinct period of time. So thank you for that. Maybe I'll ask the first question once again. So given the pull of history versus the push of the future in a rapidly changing understanding of what creates health, it seems to me we need to be very clear about what the purpose of leading health indicators will serve. And I think you laid that out in your slides, your earlier slides, about being an indicator of health and well-being in the nation. And then I think you addressed the fact that each of the sets of indicators or objectives, leading health indicators, the core set, and the research and the developmental set ought to be considered as groups of indicators or groups of objectives. And then criteria should be, applied to the collection of it. And you indicate that when you talk about the process, your phased process of looking through that. What I'm not clear about is if you go through the whole process and if you look at the collected set of objectives and related indicators, will that universe to draw from actually create the sense of purpose that the leading health indicators is ambitiously sort of set out to accomplish? So you haven't really addressed the kind of universe from which you're drawing, from which this evaluation is drawing its raw data, given that pull of history versus the push of the future, and it's a rapidly changing environment. So I wonder if you could talk about that a minute, and then I'm going to call on some of the other committee members.
Well, I'll start, and then I'm going to ask Nico and Dushanka to step in. So I think one of the reasons I took a little tangential side path to talk about the major recommendations from the Objective Review Subcommittee is that if indeed the only pool of potential candidates for LHIs are the core objectives, and the core objectives are still living in, as important as they are and as hard as it was to get down to the 350, let's say, are still living in an older model, then we're constrained by that. So I think two things. We don't know what the final set of core objectives will be, how the FIW is acting on public feedback, and certainly the major recommendations that we made. But as I said, 4 very major recommendations really addressed moving the core objectives more in line with the Healthy People 2030 framework. Depending on how that plays out, it could be we're in good shape, or it could be, gosh, maybe we need to reconsider, reconceptualize what the leading health indicators are to meet the concept and definition of a sentinel and bellwether and the whole 9 yards. Maybe we need to reconceptualize that and question, must they come from the core objectives, or are there other strong data sources or information that may contribute to even a subset of leading health indicators? And we did have that discussion in our advisory committee in terms of must they come from core objectives? So Nico, Dushanka, Ed, do you want to concur or disagree or give other thoughts?
Yes. Nico, do you want to start? Or
Sure. I completely agree with how Terry just phrased that, and we certainly brought that up in our deliberations as a subcommittee. The key to this is the final pool of core objectives, and obviously the first pass at that is limited to the subset of available objectives that were initially part of Healthy People 2020. And so the difference between the roughly 350 or so core objectives that are there now and the possible all the way up to less than 600, to stick with that definition of less than half of Healthy People 2020 number, that I think is going to be the opportunity to make sure that there is this final pool that reflects the framework at the end of the day for Healthy People 2030. And so, the definition of LHIs and how that definition is reflected in the final set of core objectives is absolutely central to this question. That said, I think there is also room to think about the purpose of LHIs, and if the purpose of LHIs can actually be met by limiting the set to the core objectives in the first place. And that is today, I think, a definition that Healthy People works under. So that may be something that needs to be up for discussion in this context. Tushenka?
Yeah, I agree with those comments. I think that we're hopeful that the recommendations you'll see from the Objective Review Subcommittee are taken to heart and that result in the addition or modification of the core objectives that were provided in draft form. And one of the issues that was raised and will be part of the objective review is taking a look at the objectives from the perspective of the overarching goals. And in order to do that, one needs those types of objectives that are allowed to cross-cut, to look at the macro level issues that drive change and support progress.
Well, this is Sandik. If I just could make a comment. If there's anything to logic, I think this is a very logical approach with two different sets of criteria, first one and then another. And I feel like Mr. Spock, according to logic, this should really make a difference. On the other hand, we don't know what this set will actually look like. And I think it is the question as to whether or not the set would motivate and provide the direction, enthusiasm, and actions. I don't know why, I really don't know why that it wouldn't. But some sort of testing, my gratuitous suggestion, I guess, would be important. That would give us a sense of how different groups would react to this. Another aspect is that I think it's difficult to gauge from this is whether the resulting LHI set does somehow cover, in a practical sense and in a sort of mathematical sense, the entire set of Healthy People objectives. In my view, it should be. It should, the way the objectives have been constructed. And yet we really don't know until we see the results.
Okay, so thank you. Let's move on to some of the other questions that the committee members may have. Sherry Johnson from University of Wisconsin, Director of Population Health. Do you have any questions? You don't have to. I'm just going to call names so we make sure everybody has a chance.
Thank you. I don't have any further questions.
Paula Lands, do you have any questions? Are you on the phone? Paula? While we're waiting for Paula, is Gilbert G?
Yeah, I'm here. Thank you for that great presentation. Really, really informative. I was just curious, as you went through and you thought about, you developed this really nice process with the, various criteria, and you did a couple iterations of it. After kind of going through that exercise, are there any criteria that you think were less important, and were there other criteria that you thought, maybe in retrospect, oh, this is something else we should have considered?
That's a good question. I personally think all the criteria were important, and all the criteria were quite consistent and driven by the framework. Were there other criteria we would add in? I hadn't really thought about that. You know, one of the early things, I'm not sure this is a direct answer, but I went back and pulled, in one of our first meetings in LHIs, Richard Klein presented what progress have we made on Healthy People 2020 LHIs. And yeah, it's a little concerning, I guess, in that, you know, 20%, 21% met or exceeded their targets. 37% are improving, but 25% no change, and 16% were getting worse. So I don't know if taking into account past progress or lack of progress in any way would inform whether something ended up in a set of LHIs or not. But that might be one possibility. I don't know. Others, what do you think?
I'm not, you know, I'm with you. I don't know what other criteria, in fact, some of our criteria are compound, right? So they have, you know, magnitude of health disparity and the degree of health equity. So sometimes you may want to tease those out. But I think that they are extremely useful. The issue is which small set of objectives would make a difference for the overall movement of the Healthy People Initiative. And so maybe even looking at all of the objectives and their progress or no change or their decrease in progress in relation to the LHIs would be useful too. I don't think we did that part.
I think.
Well, if I could, that's fine. If I could, one thought is a measure that reflects differences across the population.
Yeah.
So we're looking at phase one, the public health burden, sort of overall. What we don't get at with the measures is this notion of disparity. We talk about magnitude of health disparity, but something that would be specific to differences in the population, the spread of health or wellness, with somehow combining or being able to show the percentage of the population that is at one end of the spectrum versus the population that's at the other end of the spectrum. And that might be something that would drive.
Yeah, and so I agree with that, Ed, and I think it's sort of captured in there, but I think you're making it much more explicit. And you also make me think about, I'm holding the major recommendations from the objective review thing in my hand right now. The other consideration that we did not put in this LHI criteria, but that we pulled out for the overall objectives, was adding high priority objectives that allow comparison of health and well-being in the U.S. to other OECD nations, or recasting existing objectives to facilitate such comparison. We don't have that explicitly in the criteria for the LHIs, and yet it is one of our major recommendations for the overall objectives. And maybe that would be valuable for LHIs, right?
Yeah.
As something that we did not have in there nor consider, but might be worth giving careful thought to.
So very important point, Sung, and your point about health equity, I know is a concern or a series of questions we have for the group here. So let me move on to make sure that Paula Lands gets another chance to ask a question. I think she was having unmuting herself. So Paula, are you with us?
It looks like she's muted.
Yeah, it looks like you're muted, Paula.
I'm not muted.
Oh, there you go. We hear you.
There you go.
Can you hear me?
Yep.
Yes.
Yeah.
Okay. I don't know. My
Okay.
phone's being really, really quite odd. Doesn't want me to talk. I'm going to anyway. So first, I wanted to echo the accolades that have already been voiced by other people about all the incredibly and impressive hard work and thoughtfulness your committee has put into this effort so far. It's really, again, quite impressive. And then I did have one question, going back to the phase 1 criteria that you were talking about, and that 4th criterion of actionability that includes thinking about how an objective would contribute to the plan of action to develop and make available affordable, I'm going to focus in on that affordable issue. Affordable means of health promotion, disease prevention, and treatment, which you said, you're thinking about as the, a good value or bang for the buck. I think it's really important. It is really important to think about costs. I don't object to that at all. But could you say a little bit more how you're thinking of these notions of cost effectiveness and economic value? Because as we all know, they're super tricky. It's really hard to get good data on the economic value that different kinds of interventions or different types of progress in society might mean. And it's especially so for more upstream kinds of intervention and policy.
I'm thinking on this. So, anybody else want to jump in?
Well, I think it was more of a layered look in the actionability. I think we wanted to make sure, first of all, there were evidence-based interventions that would be able to be incorporated and used for that particular objective. I think the next issue in terms of cost effectiveness and the economic component we have highlighted on our prioritization of selection objectives, but we didn't dive into the actual methodology that I'm aware of within that discussion.
Perhaps a cost effectiveness jury that would give recommendations. I mean, I think it is an extremely difficult area, and my gut feeling is there is no specific answer. On the other hand, to just sort of, let people, decision makers, people performing interventions, developing policy, to sort of have to do it on their own. I think we can do better by getting together an appropriately diverse panel that could give recommendations regarding these. I think that comes along with what we had said earlier in the presentation about guidance. I think guidance should be there should be early and it should be early in the process for Healthy People 2030 and significant and continue throughout, for that matter.
Yeah, I would like to add, to those comments, certainly right on, but I think in our conversations across multiple subcommittees, so not only in this particular subcommittee, but also in the graphic subcommittee, as well as the prioritization, we've sort of placed that economic environment in the background as well, and considerations of cost effectiveness, and how does that show up, typically was in the context of evidence-based solutions or evidence-based interventions. So once there is an evidence-based intervention, then cost effectiveness analysis tends to be done, but not before. So if I think about, for example, all the Community Preventive Services Task Force recommendations, they don't do a cost effectiveness analysis unless there is evidence of effectiveness first. And so I think in that context, it does make sense to think about what are the kinds of actions we should make available, and then think about what does the cost of that, what does it mean to the cost side of the equation. So it's sort of balancing all of those things at the same time, but that's probably as deep as we've gone.
I'm going to add one more thing, is we actually purposefully didn't use cost effectiveness in the report to the secretary. We talked about, is it a good value? And I'm going back to the objective prioritization subcommittee report, which talks not just about cost effectiveness, but prevention effectiveness, right? So as we think about if we have good evidence, but we think from a prevention effectiveness perspective, it's going to hit a bigger swath or have more impact, et cetera, that's also a way to think about value without necessarily a formal cost effectiveness. So, you know, part of it is value is not just, I mean, I'm not an economist, but value is not just cost effectiveness. And certainly if you have effective prevention effectiveness, hopefully that's a costly, you know, a cost effective thing to do. But if we had more information on this is going to have a big impact, hit a bigger part of the population versus another intervention or focusing on another objective, then prevention effectiveness could drive how we think about where does this fit in the overall pecking order.
Okay, let me go to Darcy Phelan, who has a question, who has a clarification question. Darcy?
How did you know I had a question? It's like you're a mind reader.
Yeah, I have sources of information that are unbelievable. Go ahead.
Thanks so much. This is so helpful and interesting. In terms of the phase 1 criteria, looking at the burden, disparities, sentinel, and actionability, what are the group's thoughts on the availability of local data and sort of the phase 1 evaluation criteria? And again, I'm the chief epidemiologist at the Baltimore City Health Department. So I'm always thinking about, you know, obviously what can we measure locally within neighborhoods to direct our resources. So I wondered if the group thought about the availability of local data and developing the criteria.
We did not necessarily focus on that, but as Ed has said, we definitely have placed an incredible amount of emphasis on the value and need for local data and the guidance for it in order for it to be able to be used and rolled up to the national. So and we also understand that some of the data innovation happens at the local level that could really help us then inform the national monitoring as well. But as far as I recall, and others can say, we didn't take that into effect in this 2-phase process. We didn't think about it in that light.
Yeah, I think we were thinking of, go ahead, Nico.
So I think we had a sort of a set of assumptions going into the LHI subcommittee that if you start with core objectives, then it would already be a given that there would be data available. And then from that flows the rest of the recommendations that relate to the making the actions related to those core objectives as local as possible, because that's where most of the action is going to happen. So then it didn't really show up in the discussions related to the LHI subcommittee, but clearly it would show up again in the data-related recommendations for seeing action happen at the local level.
Yeah, because I think the LHI stuff really was focusing on the nation's health as a whole. So it really did start at that level. But I'm thinking, like, I'm looking at, for example, in 2020, one of the leading health indicators is air quality index, right? So in Baltimore, like I know in Philadelphia, I work with the EPA and the U.S. Forest Service, and we can get regional local air quality index that we may drive our action in Philadelphia because that's high priority and would feed into. But the fact that we have data in Philadelphia probably would not drive, does this belong as a leading health indicator? That's how I'm thinking about it right now.
But I think, Terry, you raised, I think, a really good point from the point of view where we have national data that can go down to the local. So that's sort of the other direction that might give another level of flexibility and actionability, right?
Yeah.
Because you're able to have it in hand on a routine basis and follow it through.
can I turn the question back to you? Is that okay, George? Can I just turn the question back? So you're in Baltimore and the health department. Can you think of an example or give us an example of how we could think about that, going from local to national, from your perch?
Well, certainly. So, you know, when I think about a leading health indicator, you know, just in general in public health, I think about infant mortality. And Baltimore has really struggled with infant mortality and has pulled together, the health department works with a coalition of over 100 community groups to try to reduce infant mortality. And since 2009, the infant mortality rate in Baltimore City has dropped 40%. So we're very proud and excited about that work. And while the infant mortality rate for the city overall still needs a lot of work, we know that neighborhood by neighborhood, there is a lot of heterogeneity within the city. So when we are able to look at it neighborhood by neighborhood, we know where to direct our resources. And so we can take more localized action even within the city on that indicator. And so that's just the kind of thing I'm kind of thinking about is, you know, the type of data that are available to local health departments. You know, they're pretty limited unless they're administratively collected by another group and they, you know, share the data. But as a local epidemiologist, you know, I'm so excited about the idea of leading health indicators that could be measured and addressed at the local, state, and federal level. Like, to me, that just sounds like totally awesome. And so that's
good. So let's move along. We've got a number of other important topics to cover, and I indicated we wanted to actually, the committee had questions on equity. So I'd like to call on Sherry Johnson to ask a question on that.
Thank you, George. And I do echo that this has been really rich and informative. So thanks for all of the work. Back to sort of the relationship between the notion of interventions being affordable. I'm wondering how the committee is thinking about and defining equity, and whether you're using people like Paula Braverman et al.'s definition that really talks about health equity being a values-driven goal that requires removal of unfair obstacles to health, and how you might be thinking about balancing that with decisions around whether something is affordable and whether decision makers should advance policy related to a particular intervention.
So that's the wicked problem. And yes, in our brief for health equity, we definitely use Paula's definition and also provide, you know, the numerous definitions that are there, and we look at inequities as well as health disparities. So as we look at these 4 phase 1 criteria, they are rich, right? And they do have that interaction. I don't have an answer for your question because, you know, clearly to address health equity as you defined it, or as Paula has defined it, is extremely intense in terms of costs and a huge commitment. But that is the challenge, I guess, in doing these criteria. And we never really, you know, Terry, remind me, I think we had a discussion about weighting, but I don't think we ever, you know, implemented it because it wasn't simple and elegant. But I'm sure that those are the kind of things that, of course, can be considered if there is enough information of, you know, useful information or data to base it on.
So again, this is George making a comment on that answer. I think, you know, the criteria definitely call that out in phase 1, but applying the criteria against the existing set of core objectives may not yield a result that really addresses the fundamental issues of equity in the population.
Right, right.
So you have to wrestle with that issue as well, I would think.
Well, yes, and yeah, I think you're absolutely true. And we actually did, sorry, I'm back to the Objective Review Subcommittee, had a whole sort of detailed report on how did the proposed set objectives address health equity.
Thank you.
Yes, you're constrained with, you're sort of constrained within what ends up in those core objectives.
Yep. Let me turn to Martha Gold. I know she has a long list of questions.
Hi there. Thanks very much for the leading health indicator conversation. That was actually very interesting to understand that there may be a whole other set of core objectives coming down the pike that we can consider. I wanted to ask a little bit more about the method, Terry, that you were describing of sort of your exercise with the 24 leading health indicators from 2020, and thinking about the utility of that and doing it for 350 or 600 core objectives. I'm thinking that would be quite challenging, and to hear some counsel you might have about that. But the other thing I wanted to ask about that, and this is one of my concerns, is when you look at magnitude of the health disparity and you look at public health burden, you're certainly asking sort of subjective views of people who have a wide range of different kinds of views on those areas, but those are not necessarily based on granular data, as I'm understanding it. Those are sort of kind of opinions. Yes, is that correct? Because, I mean, let me
other people can answer this. I'm not sure it's all opinion. I mean, I think it's, if you think about public health burden, if you just go back to go back to morbidity, mortality, I mean, there are data on things like that. I think, so I don't think that's just opinion driven, and Ed, you can kick in on this as well. I think the magnitude of health disparity, for example, not all the core objectives have, health disparity data broken down. That's one issue. B, they were trying to add things this year in terms of like sexual orientation, gender identification, etc. But those are still looked at in sort of siloed things like rural, urban, race, age, versus what happens if you're a young Black man in an urban area. So even when there are data, there's limitations there. But I don't think it's just opinion. Ed, do you have any thoughts on that?
When we were discussing it, I didn't see it as opinion. I saw it as looking at the data that we have.
Yeah.
So that's actually my question. So when you actually looked at the disparity piece, were you looking at those 24 leading health indicators and sort of parceling them out on the basis of sort of socio-demographic?
Yeah, so I will say in the exercises we did, we weren't totally driven by data. We were looking at, is this a process that could work? But actually, if you look at the mid-course review, and I think this will be, which is probably what is the most recent to work at, you can dig down into all the leading health indicators and look at specifically at disparities within those, for example. So those data for the ones that are existing or the core objectives that have disparities, those data are available.
Thank you.
Martha, additional questions?
That's good.
Okay. Other questions from the committee? Let's make sure that we don't have any comments from the public at this point. While people are thinking if they have additional questions. Alina, do we have any emails that indicate public comment or questions? Alina, you with me? Alina? So I'm not sure if I'm connecting with Alina. I do have a note from her that says that there weren't any questions as of a few minutes ago. So I'll come back to her in a minute if she has an update on that. So other questions from the committee? Anybody on the committee?
Speaking, can you hear me?
Yep, go ahead.
I just was interested in looking at the leading health indicator commentary from the 2020 objectives, reading that committee's report. It looked as though there was a strong recommendation about economic hardship and trying to figure out an indicator that might be useful there. I wonder whether this committee has had some conversation about that they might share.
We have not had conversations about specific potential indicators, since we're not the ones who would pick those. We've had our conversations really have centered around how do we think about it, and how would you go about selecting. That said, we have had. I'm going back to the Objective Review Committee report, is the importance of getting broader, cross-cutting factors that we know drive health, and are those data available, et cetera, and can they be infused into Healthy People 2030? Nico Dushanka, any?
I think that's correct.
No, it's definitely correct, and it's making me think, similar to our discussion about data partnerships, local data, that this is an area that also would benefit from continued discussion, or maybe initial discussion and continued into the early part of the decade to consider.
And I'm going back to the, not to change the question, but even in the Health Disparities, Health Equity brief, the discussions about the overwhelming impact of racism on health, right. That could be a leading health indicator, if that's right. Available, are there data, et cetera. So I think, again, as we think about really conceptually the focus of the framework for Healthy People 2030, it is loudly inviting us to think about that as what really are the leading indicators of health in the nation. And if we balance it between, the health states, but these other factors that we know are driving a cross-cutting bad health and bad wellness, we have to somehow grapple with that, I think.
Profound thought. I see Jonathan Skinner now has his hand up. John? You're muted, John, if you're trying to talk. Looks like your phone is muted.
All right.
John, are you there?
Yep. Can you hear me now?
I can hear you now. Thank you.
Okay. Sorry. Yeah, I had to unmute twice, which I didn't pick up. So, I want to sort of reemphasize what Darcy and others. Sorry?
Yeah, go ahead.
I wanted to reemphasize what Darcy and others had said about looking at things at the community level. I mean, the analogy is looking at GDP growth.
for the nation, but not looking at what's happening to the bottom 10% or the top 1% in terms of income. And I think it's also, when one is thinking about dropping the indicators down, because even 300, I think, is too much for a human being to comprehend, that one can actually do this in a systematic way, in the same way that if you buy, say, like 8 stocks, that you can pretty much replicate the S&P 500 if you pick the right 8 stocks. That is, a lot of these measures are all going to be correlated and actually aren't that useful individually, because they're all kind of mixed up with all the other things. So I would recommend, if possible, when it comes time to sort of thinking about what things to kind of scale back on, that it's possible to use actual statistical approaches to help guide which ones you choose for deletion.
Comment on Jonathan's point? Any comment from folks on the advisory committee?
So if I follow that comment, if it's possible at all to base any of the prioritization of LHIs on statistical approaches, I think that would be a great opportunity to try and do that. I think there's going to be a need at some point to sort of think about that second phase that we introduced, this notion of iterative and looking for balance across the board. That may not be available or may not be possible to do that statistically, but certainly if it's data driven, the more data driven would be, the more you can do with that approach, I think the more effective it could be.
Okay, I still see hands risen by John Skinner and Martha Gold on the participant list. Do either of you have additional questions?
I didn't mean to have my hand up, George.
I'm sorry?
I didn't mean to have my hand up.
Okay, thanks, Martha. And I see Jonathan removed his as well. Are there further questions from other members of the committee? Alina, let me check in with you once again with respect to whether there are any comments from the public or questions from the public.
Are you able to hear me?
Yes, I can. Thank you.
Okay, great. I think maybe I had to unmute twice or something like that too. Yeah.
And the answer to my question about public comments?
I have not received any questions from the public at this time.
Okay, terrific.
Thank you.
One further call for questions from the committee.
I saw a question from Sherry, but I don't know if this is a question she's already asked. There was a follow-up about the health equity issue. Sherry, was that a related question or have you already asked it?
I asked the question about equity, but I was also looking at a question about the frequency of data collection. In one of the pieces of material, it says that there needs to be at least 3 points available for data collection, a baseline, and at least one in the decade. But then in another piece, I think we saw that there should be availability of data on an annual basis. And so I'm wondering if there could be any additional clarification about how those data criteria apply to selection.
Yeah, let me start by answering that, and then I would invite Ed to speak as well. If as part of the core objective selection criteria, one of the criterion was related to having at least 2 data points in addition to a baseline. So it may be that the baseline comes from the previous decade, but that at the end of the day, Healthy People 2030 can base trend on at least 3 data points. So that's kind of how it was positioned. Ed, do you have any additional insights there?
The annual was stressing that the information, when collected, needs to get out quickly. So it should get out by within a year.
Okay. Other,
it was the 3 data points. I don't think that the committee was entirely, the subcommittee was entirely comfortable with only 3. But when you look at the data sources for for many of these objectives, it's difficult to get the data more frequently than that. But it does raise this question, to go back to the community level or the local level. It may be possible for epidemiologists and other people at the community or local level to combine data sources in such a way so that they can get estimates on a more frequent basis. Again, that gets into guidance, it gets into quality and how to use the data, which we have addressed in the sense of wanting to get as much guidance out as possible and to get it out early.
So if I'm understanding you correctly, then even if a survey isn't administered annually, it should something should be reportable annually. So is that correct?
No, not exactly. If some data sources, I'm thinking specifically at the national level, are such that the data cannot, I shouldn't say cannot, it's a matter of, I guess, will and dollars, but currently the sources that are used can't produce data annually. I'm thinking of, for example, NHANES, National Health and Nutrition Examination Survey. But the committee, the subcommittee, and the committee felt that it was important to have at least these 3 data points, perhaps 1 from the prior decade and then 2 new ones. 2 points don't make a trend, and 3 points sort of make a trend, and you can quote me on that.
All right.
But
Thank you.
Then the additional annual was also related to, if there is data collection, that at least the reporting of that data would be coming out within a year after.
Right.
I'm glad to update my understanding of what makes a trend. So thank you. Other questions from the committee? I wonder if Alina or Martha have a question.
So thinking back about some of the discussions that we've had today about state and local and national data and harmonizing perhaps, would your guidance be for this group to think carefully about data elements that might be in the state health ranking project or in the county health rankings that also, were within the core objectives? Would that be something useful for us to consider, from your opinion?
We certainly can. We certainly were aware of that information. I'd say yes. I say yes. But I think guidance as to how to use this information related to its quality and the drive to use the information to make decisions, with the notion of getting at how much is really how to judge quality in terms of the decision. The American Statistical Association just had a issue of its major journal that focused on confidence intervals and the sort of use of bell-shaped thinking, like 5%, and with expressing strong opinions that there have to be better ways of doing this. And I think that very much relates to data use in Healthy People 2030.
So I'm going to kick in. I think if I understand the question, and maybe I'm not, but if in selecting leading health indicators, all other things being equal, if it's big, if it let's say meets the criteria that we're recommending, and then, gosh, if I'm looking between two and saying I want to pick one of these two, and one has really comparable data at the national, state, tribal, local level, to me that would be a check plus, right? That could be a really good thing, because it's a way then to show NLHIs how powerful potentially that could be, if I'm understanding what you're asking.
Indeed, it is, and thank you very much.
Other questions from the committee?
George, this is Alina. I have a clarifying question. This is with regard to the Objective Review Subcommittee report. I was wondering if that report is expected to include the final set of Health People 2030 objectives. And also, what's the estimated date that may be available to us? And could you say a little bit about the process or the considerations for winnowing down, and maybe what's the total number that you're looking at? If not 350, what might that be? If you're able to speak to that.
So Tiffany, I think, would be in the best position. We know that it's at the secretary's level, but the report will not include a listing of the objectives.
No, and I don't think that they would, because we're not picking the objectives. We're only advisory.
Right. Yep, and I would say, this is Tiffany. I'll add on to that. That is correct, what both Terry and Dushanka have said. And I also make the note that they reviewed the slate of objectives that went out for public comment. And the slate of objectives that will go to the secretary will include any updates that have been made to the slate after public comment, after all the comments received have been reviewed by the topic area work groups and the FIW. So there will be an updated slate of objectives post-public comment that will be shared with the secretary.
Do you know when that will be, Tiffany?
We don't have an exact timeline yet. We're still working on finalizing that slate and target setting methods. So we're planning to hopefully send to the secretary or send through departmental clearance within the next 2 to 3 months. But again, that's not finalized yet, but that's our estimated timeline. And then once it goes for departmental clearance, there may be multiple rounds of review of that slate. So that's currently where we are.
And then I'm going to add one thing to that from so the Objective Review Subcommittee report's not available, but the slides from the full committee meeting are public domain, right, Tiffany, and are on the Healthy People website. And the slides from the full committee meeting do have embedded in them the recommendations.
Right.
Right. That is correct. So anybody can go online and look at that. So that's just a reminder. The second thing is, I think you said, Alina, and is it going to winnow down the objectives? I don't think the Objective Review Subcommittee recommendations or report was intended, nor will winnow down the objectives. I think it's our hope, based on the recommendations, is it's going to add some objectives. Nico DeShanka, do you?
Yeah.
No, I agree.
You're exactly
to
correct.
get to the balance and to address the framework component.
Yeah.
And the reason was because at this point, the number of objectives in the slate as it is today is around 350. And by definition, it has to be less than 600. So there is room rather than focusing in on winnowing down. It just asking the question, is this the right balance?
Great. We have a couple of minutes till the top of the hour. Alina, do we have any comments from the public that you want to put on at this point? So I don't have any indication from Alina or any of my various public sources of information that we have any comments. And we're approaching the top of the hour. So I think I probably want to, one, make sure that I thank the presenters from the subcommittee or the committee and the subcommittee from the advisory committee. I think it's very, very impressive, speaking for the committee, the work you've done. And I think it shows in terms of the presentation and the commentary you've made, as well as the answers to the questions that you provided to us. So we're very, very thankful and grateful for this opportunity to improve our understanding of your work and to move forward with our own part in that same way. So thank you very much. Don Wright, Nico Frank, DeShanka, Terry Richmond, and thank the members of the committee for joining us and appreciate all of that. If there's nothing else, Alina, I will, or from either DeShanka or Nico, I'll close the meeting at this point.
Just a big thank you, and thank you to the committee for the wonderful work you're embarking on. So,
yeah, same here. Thank you very much for the invitation.
Very important.
Thank you.
Thanks for the invitation.
Okay. We stand adjourned then. Thank you very much.
Okay.
Thank you.
Bye-bye. Bye.